COVID-19 pandemic has been an evolving situation. First, it was a virus that we all could do was practice good hygiene and social distancing. Then we had more guidance, and then a vaccine. Today, we're actually going to turn our attention to new treatments that are available to treat COVID-19. To do if you need to manage COVID-19 at home. This webinar helps Allergy and Asthma Network continue to move our mission forward. Our mission has been the same since we began in 1985, to end needless death and suffering due to asthma, allergies, and related conditions through a four-pronged approach of outreach, education, advocacy, and research. Today, we are pleased to have Ron Rideman from Regeneron Pharmaceuticals here with us. Ron has 30 years experience as a licensed pharmacist and has spent 20 years as a medical science liaison. He is currently the Associate Director of Early Phase Clinical Development at Pharmaceuticals. Thank you for joining us today, Ron.
It's my pleasure.
Great. Today's program will include several different topics. We'll start out, as we always do, with the current state of COVID-19. And then we'll turn our focus to the antibody therapy for COVID-19 and different treatment opportunities. Finally, we'll spend the balance of our time looking at how one should care for COVID-19 at home and when perhaps they should seek emergency medical care. As you all know, we enjoy participating in polls throughout these webinars. They're very insightful. So we're going to go to our first poll today. We'd love to know who's here with us. And so please share with us which story that best describes you. We have about 1,000 people registered for our webinar this afternoon. So are you a physician or pharmacist, a physician assistant or nurse practitioner, nurse, school nurse, respiratory therapist, asthma educator or health educator, or a patient? So we'll give everyone just a moment to complete that, and then we'll share the results collectively. We always have a very diverse group, and today is no exception, as we now have about 2/3 of participants logging in their response. We'll give it just another second and then share. All right, let's see. So today it looks like we've got 6% physician and pharmacist, 3% physician assistant and nurse practitioner, 5% school nurses or nurses, 20% respiratory therapists, asthma educators and health educators, and 6% patients. So again, welcome everyone. We look forward to your different insights and feedback as we go throughout today's webinar. So what is the current state of COVID as we sit here today in mid-February? As of today, February 17th, the Johns Hopkins global map reflects that we are quickly approaching 110 million global cases of COVID-19 that have been confirmed. In the US, that number is quickly approaching the 28 million mark. And you can also see here on the Johns Hopkins panel that the global death toll is nearing 2.5 million people, with almost 500,000 of those coming directly from the United States. Again, we always turn to the Johns Hopkins data as the most reliable for the global and most up-to-date information. We also turn to the CDC to look at the daily case rates and the new case rates. And so as you can see, the darker blue indicates those where the case rates are higher throughout the country. And here in the last 7 days, Texas and definitely South Carolina and some parts of the Northeast tend to have the highest case rates. But the good news is that we've begun to see these daily case rates significantly decline over the last few weeks comparative to the period of November, December, and early January. Now, what about in the headlines? What's making the news over the past 2 weeks? First, many states are actually expanding their access to the vaccines. And at this point, the concern is more around the supply. Fortunately, the supplies simply are not keeping up at the same pace. We do have widespread vaccinations, hopes that by the summer, most people will have access to a vaccine if they so choose and desire. There's also an Israel study on the Pfizer vaccine that indicates a 94% drop in symptomatic COVID-19 cases. So this is very promising as well. And then, unfortunately, the number of coronavirus variants continues to rise. And the latest report is 7 different variants that have been detected throughout the US. Now, again, as I indicated, this is a trend line that we are very excited to see. New cases by day have continued to decline over the last 3 or 4 weeks significantly. And so again, while we're still at over 50,000 new cases per day, it is rivaling back to the time frame of early to mid-September versus the peak that we saw throughout November, December, and January. So now let's go back to our polling. What do you think is the early estimate for the COVID-19 recovery rate? So we'll launch that poll. Do you think that it is 65 to 72.5%, 97 to 99.75%, or 80 to 92.5%? So or below 60%. What do you think is the early estimate for the percentage of people that will actually recover from COVID-19? We'll give this just a moment. Do you think it's around 2/3 to 3/4, greater than 97%, or that 86 to 92 in the middle, or perhaps below 60 that will recover from COVID? We'll give it just a second. Looks like we've got about half of the people that have cast their votes, so we'll give it just another moment. All right, looks like most people have logged in, so I'm going to go ahead and close the poll and share the results. So it actually says that 30% of you believe that about 65 to 72% of people recover, 18% say that 97 to 99.75%, 44% at the 86 to 92, and then 7% below 60%. Surprisingly, the actual correct answer here is that 97 to 99.75% of people will actually recover. So that's good news. For those of you who do get COVID or have had COVID, again, greater than 9 out of 10 will recover. So at this time, I'm going to turn it over to Ron and ask him to go through some of the in COVID-19 for us today. Ron?
Thank you, Tonya. And it's my pleasure to be here with all of you today. I did want to state that because there are patients in the audience, that for those of you that are healthcare providers, I will be speaking in this presentation at the patient level because I have spoken to large audiences in the past, and it's always been my objective to make sure that everyone in the audience can understand what I say. For the physicians, physician's assistant, nurses, pharmacists, and other healthcare providers who have sat through many a high-level science presentation, that's not what I'm going to deliver today. What I'm going to do is I'm going to talk to the patients, and of course, then each one of you will also then be able to understand what I'm stating. So, unless you're over 100 years old, we are all going through our first pandemic together. And this slide was dated as of February 3rd, but the current numbers are over 28 million cases in the United States. Unfortunately, we just surpassed over 500,000 deaths in the United States. And about the only good news related on this slide. Go back one slide, please. The only good news on that slide is the decline in this curve over the last few weeks or so. So hopefully that's indicative of all of the precautionary measures that we're taking, the vaccines, that they are now beginning to make an impact, yet you can still see that the number of cases is at nearly an all-time high. Next slide. So today we're going to talk about tools to fight the pandemic. But I'm not going to spend much time talking about vaccinations. You have surely seen lots of information about vaccines over the internet, on the television. Today, I'm going to talk about other available therapies. Specifically, I'm going to talk about monoclonal antibodies, and did want to let you know that the monoclonal antibodies that are available today for the treatment of patients with COVID-19 are available under what is called an emergency use authorization. And that emergency use authorization specifies that ambulatory patients and patients that are hospitalized for reasons not due to COVID-19 are the patients that are eligible for receipt of monoclonal antibodies if needed. There are plenty of drugs available for patients that are hospitalized. And in medical science, we've learned a lot about the drugs that are available to us to treat patients in the hospital. But today I'm going to talk to you about the monoclonal antibodies that are being utilized to treat primarily ambulatory patients. Next slide. So what are antibodies? When we encounter pathogens like the SARS-CoV-2 virus, and the pathogen could be a bacteria, could be a virus, it could be other, then our body responds by producing antibodies. And these antibodies will kill or neutralize the pathogens. And one of the cool things about our immune system is that it has its own memory. And after we've been infected one time by a particular pathogen, your immune system will remember that next time that you're invaded by that same pathogen and will deploy an army of antibodies that they've already developed against that invading pathogen. Next slide. So let me explain a little bit about our immune system. There's two types of immunity. Innate immunity is the immunity that we're born with. We get that from our mom when we're in utero. But the immunity that we gain during the course of our lifetime is called adaptive immunity. And that's because our bodies are adapting to its environment. And there are two types of adaptive immunity, both passive and active immunity. And these use the protective antibodies that we're going to be speaking about today. Next slide, please. So I mentioned I wasn't going to be talking about vaccines, but I am going to explain a little bit about the difference between a vaccine and an antibody on this slide. So first, I'd like to draw your attention to the right side of the slide. And vaccines are created using antigens. And the word antigen is derived from two words, antibody generators. So antigen itself is a word that we use very frequently in medicine, but it is an antibody generator, such as a weakened or attenuated virus, a dead or inactivated form of the virus, a fragment of the virus, or the virus's RNA or DNA. And this is how the vaccines that we're so accustomed to receiving are generated. That's how they generate the antibodies in our body. And in particular, these last two are the primary approaches that are being employed for the COVID-19 vaccines. Whereas one back, please. Antibody medicines are derived from patients like you and like me who have recovered from a particular virus. And again, in our case, we're talking here about COVID-19, the SARS-CoV-2 virus. And you've probably heard about convalescent plasma. And that is given to some patients under an emergency use authorization who have contracted COVID-19. And what that is we draw blood from patients who have had COVID-19 and recovered. And then we are able to administer their plasma, which contains antibodies to help you fight COVID-19 if you're infected and you need some additional support because your body's not fighting the disease on its own. Likewise, over the last about 2 decades, scientists have been able to genetically humanize animal models and their immune systems so that when an antigen is presented into this mouse, they actually produce human antibodies, not mouse antibodies. They produce human antibodies. And in the pharmaceutical industry, we can harvest those antibodies and we could evaluate them for which are the best to move forward with in regards to advancing into clinical trials. And then we put them through a very rigorous clinical trial process, evaluating safety and efficacy. And if they demonstrate both safety and efficacy, we will apply to the FDA for a license. And if approved, we can then produce these antibodies in large bioreactors and make medicines, the antibodies, the monoclonal antibodies that we're able to help treat you with. Next slide. So what are antibodies? I've been talking about them, but what are they? Antibodies are substances that block the ability of a pathogen to bind and infect our cells. So here, let's say this is the SARS-CoV-2 virus. And these spikes that you see protruding from the virus are indeed called spikes. They're spike proteins. And interestingly, if you were to look at the actual coronavirus under a microscope, you would see lots of these spikes. And they look like crowns on the body of the virus itself, hence the name coronavirus, corona meaning crown. These structures that look like Ys are how we depict what an antibody looks like. This is a very common depiction of an antibody. And antibodies, in the case of the coronavirus, bind to the spike protein or a particular portion of the spike protein, and they prevent the virus from being able to attach to what we call a receptor on our own cells. Picture two puzzle pieces. So our cells as one piece of the puzzle and the coronavirus as another piece. And if the antibodies weren't present, the coronavirus via this particular spike protein, that's the piece of the puzzle that fits into our proteins on our cells, so that the virus then is taken into the cell, where it then produces more virus, kills the cell, and releases additional or new copies of the coronavirus inside our bodies. But with the presence of the antibody blocks the two puzzle pieces from connecting, and therefore prevents the coronavirus from being taken into our cells. And eventually this is broken down by various different methods in our bodies and eliminated in a very harmless way. Next slide. So we've heard lots about the coronavirus, SARS-CoV-2. We also have heard lots about coronavirus mutations or variants. And unfortunately, the coronavirus, which is what we call an RNA virus, has the potential to mutate rather quickly. And the mutations that occur in the coronavirus typically occur in that spike protein that I just was talking about. And if a mutation occurs, that can decrease the ability of an antibody to neutralize or kill the virus. So let me explain how that occurs. So here the spike protein is depicted as such, and this is a picture of the antibody. And if there is a mutation in this spike protein, then this antibody is unable to bind or fit in to the spike protein like it should, and therefore the bond may not be as strong, or it may not even bond at all, and the virus can escape the activity of the antibody, the monoclonal antibody. But the good news is that the probability of a virus mutating at multiple binding sites is much lower than the probability of the virus mutating at a single binding site, which is so much more common. And at Regeneron, we developed two antibodies to bind to these spike proteins. And in so doing, minimize the likelihood of a mutant being able to resist the effect of the antibodies, and therefore we can continue to neutralize the virus and the variants. And today, the combination of Regeneron's two antibodies of casirivimab and imdevimab are effective against all known variants across the world, including the UK variant, the South African variant, and the Brazilian variant. Next slide. So how do we know they work? Okay, so now I've taught you a little bit about the immune system, a little bit about antibodies, a little bit about how antibodies work, but I haven't demonstrated any data to you that proves that they work. I'm going to go into that right now. At Regeneron, we have a very robust program studying our antibodies in COVID-19 against the SARS-CoV-2 virus. And the data that I'm about to show you is from what we call our study 2067. And this is in the non-hospitalized ambulatory patients that I spoke about earlier. And this is why the data from this study is why we have an emergency use authorization for patients that are ambulatory. We also have a study in patients that are hospitalized. We also have a study in household contact prophylaxis, meaning that if you are a healthy caregiver of a family member, a friend, someone that you're caring for in your household or in theirs, and they are infected with COVID-19, we are studying giving you as the healthy person a dose of our antibody to prophylax, to prevent you from getting the disease. And in fact, we have some very good interim results from this study. Here, the drug is given subcutaneously, so it's an injection. But in these other studies, you can see our antibody combinations are administered intravenously. And we also have additional studies that are ongoing. And the number of patients enrolled as of January 28th of this year totals over 12,700. So as you can see, it's a large program, and we're collecting a lot of data, most of which we have now around ambulatory patients, but soon data will be available in our hospitalized patients and also from this study in household contact prophylaxis. There's also a large national study going on in the United Kingdom where our antibodies, casirivimab and indevimab, are being used. And that's called the recovery trial. And there'll be some very interesting data available when that study is completed. Next slide. So this is a slide that those that are healthcare professionals in the audience are probably very accustomed to seeing at all of the medical meetings that they attend. But I'm not going to present it like I might present it there. I'm going to present it so that everyone can understand this. And what we studied in this 2067 trial, part of what we studied, was whether or not the combination of our two antibodies, and here you're seeing the names of them, casirivimab and indevimab, reduced what we call viral load from baseline. Viral load is the amount of virus in your body. And if this was baseline, you want to reduce that viral load. So you can see where I'm tracing the curve, and you can see that we were able to reduce the viral load with both our low dose and our high dose drugs. We were studying this in 2 different doses because remember, we didn't know what the dose should be at the time. So we were looking at different doses. We now know, and we focus on the 2,400 milligram combination of 1,200 milligrams of each one of these 2 monoclonal antibodies. And that's what you would receive if you were ill with COVID-19 and your physician prescribed for you these antibodies to help treat you for COVID-19. We also learned an interesting fact that the largest viral reductions were seen in patients with the highest viral loads at baseline. That makes sense. Think about it. That if you had the greatest amount of virus in your body and you were giving given an agent, an antibody, to fight the virus, then you're going to see the greatest reductions in the patients that have the highest amount of virus. And that's what we saw. Next slide. Something else that we looked at, because reducing virus is great, but does reducing virus alone tell you that the drug actually works? What does it translate to if we just took that in a vacuum? Well, we didn't. We also looked at whether or not when you get the combination of these two monoclonal antibodies, if there is a reduction in medically attended visits. And we defined medically attended visits as hospitalizations, emergency room visits, urgent care center visits, physician office visits, and even telemedicine visits. And in this study, in patients that were on the low dose of the two monoclonal antibodies, there was a 57% reduction in the utilization of those healthcare resources that I just mentioned. A couple of other interesting facts. At the beginning of the study, we wanted to see if all the patients had antibodies or not. So we tested them. Remember, these are patients that were tested positive for COVID-19. And we wanted to see who was mounting their own immune response and who wasn't. And we called those patients that did not mount their own immune response antibody negative because they were not producing enough measurable levels of antibody to be detected. And in that group that did not produce their own antibodies, but yet received the combination of casirivimab and nivolumab, there was a 65% reduction in the low dose group in utilization of those healthcare resources that I mentioned now. If a patient did mount their own antibody response, so they have antibodies, their body recognized the invader, their body produced antibodies, and their body's been fighting against COVID without the introduction of drug. But when we did introduce the drug in the low dose, there was no additional or very little additional effect, no what we call statistically significant effect for those patients that were mounting their own antibody response, or they were what we called antibody positive. In the high dose group, there was a 46% reduction. But we've now moved away from any further study of the high dose group because we've determined that the low dose group would be the optimum dose. Next slide. And how about safety? If we apply to the FDA to get these drugs approved, we could demonstrate efficacy to the nth degree. But if these drugs or any drugs aren't safe, then they're not going to make it too far. Safety is of critical concern to all of us and to the pharmaceutical industry and to all of the government regulators. So here we're looking at the safety profile observed in this 2067 program. SAEs stand for serious adverse events. Most patients commonly call these side effects. And in the placebo group, there were 6 patients out of 262 that had a serious adverse event. In the low dose casirivimab and nivolumab There were 4 serious adverse events out of 258 patients that received these medications. And in the high dose group, again, we're no longer studying the high dose group, but we did capture this data. Out of 518 patients, there were 2 that had a serious adverse event. We also looked at hypersensitivity reactions. And these are much more severe reactions. And there was 1 anaphylactic reaction that was reported in the casirivimab and indevimab group. That occurred within 1 hour of the completion of the infusion. The good news is that we have a recommendation that patients be observed for at least 1 hour. That's in the emergency use authorization as part of the criteria. So this patient was still in the physician's office at the time. They received a dose of epinephrine, which is very commonly employed to treat hypersensitivity reactions, and that led to a complete resolution of the event. We also looked at infusion-related reactions, itching, redness, swelling, other infusion-related reactions of what we call grade 2 or higher, and infusion reactions are rated on grades 1 through 4. And in the placebo group, 1 patient had an infusion reaction. In the low-dose casirivimab and indevimab group, no patients had an infusion reaction. And in the high-dose group, 4 patients had a reaction. When we looked at treatment discontinuation due to an infusion-related reaction, 0 in the placebo group, 0 in the low-dose casirivimab and indevimab group, and 2 in the high-dose group. Next slide. So what did I just say? A lot of stuff. Well, let me summarize that for you. The results from the placebo group demonstrated that non-hospitalized or ambulatory patients were more likely to have 1 or more medically attended visits if, when they presented, so that's baseline, they were seroantibody negatives. In other words, you weren't mounting your own immune response, or at least there was no measurable immune response that we could identify. And these patients also had the highest viral loads, of highest amount of virus in their body. And this is just a measure of that. But those patients also had 1 or more risk factors. And I'm going to talk to you about the risk factors here in a minute when I talk to you a little bit about the emergency use authorization. Casirivimab and indevimab reduced the number of medically attended visits in all groups versus placebo. But that greatest reduction was in the group, as I mentioned before, that did not mount their own antibody response. So those were the folks that had the highest levels of virus. And casirivimab and indevimab had an incidence of serious adverse events of 1.6% in the low dose group and 0.8% in the high dose groups. Next slide. Okay, so who are the patients that are eligible for monoclonal antibodies under the emergency use authorization? Those patients are adults and children 12 years of age or older who weigh at least 40 kilograms. 40 kilograms is 88 pounds. Those patients will have had to have tested positive for SARS-CoV-2 virus and be at high risk for progressing to severe COVID-19 and or hospitalization. In high risk, the risk factors are defined here. So those would be patients that are overweight with a body mass index greater than 35, or they have chronic kidney disease or diabetes or they're undergoing chemotherapy, or they have a suppressed immune system due either to a disease or the medicine that they're taking, and patients that are 65 years of age or older. For patients that are 55 years of age and older, they would have to have cardiovascular disease or hypertension, chronic obstructive pulmonary disease, or other chronic respiratory diseases. And for patients that are 12 to 17, they would be those that have a body mass index greater than the 85th percentile of their peers, or sickle cell disease, or congenital or acquired heart disease, or a neurodevelopmental disorder such as cerebral palsy, or chronic respiratory disease requiring daily medications. Next slide, please. So, for those of you that are patients, and that does include those of you that are healthcare members in the audience, because at some time or other, we're all patients. Part of our challenges have been in getting the word out there about monoclonal antibodies and the opportunity presented by them has been unawareness. Patients have just not been aware, and even healthcare providers have not been aware of the availability and the utility of monoclonal antibodies. I hope that the presentation that I just gave helped to inform you sufficiently to, at minimum, have raised your level of curiosity and awareness, so that if I didn't answer your questions, that you can seek out some more information, and I'll provide that in a following slide to help increase your level of awareness. So if one of your loved ones, family members, friends or family of your acquaintances, if they get ill, encourage them to see their physicians. And if they are not hospitalized and they are getting sicker, make sure you let them know to talk to their healthcare professionals about the availability of monoclonal antibodies, because this is not the time where you would get a vaccine. This is the time where you would need to have treatment by a monoclonal antibody. Next slide. So here's that website that I mentioned, regeneroneua.com, and you'll find lots of information here if you're curious and interested, and I would highly recommend it. I've been through it. It's very insightful. Next slide. So I'd like to just close by stating that antibody medicines can serve as an important bridge to a vaccine. And they can also have utility beyond for certain people, such as those that are immunocompromised or those that don't respond to a vaccine. In both approaches, vaccines and monoclonal antibodies are important and necessary to hopefully end the COVID-19 pandemic. Thank you very much for your time and attention today.
Thank you, Ron. We appreciate that. So now I'm going to turn to a bit of information about, for those of you who are not needing to seek emergency care or hospitalization, how you might care for COVID-19 at home based off of the best evidence that we have to date. So the CDC recommends that if you do have a fever, cough, or other symptoms, then certainly red flag, you may have COVID-19 at this particular time. Most people actually do have mild illness and are able to recover at home. So if you think you've been exposed to COVID, it's important that you contact your healthcare provider and stay home. Continue to worsen. Some with COVID-19 may need to go to the hospital, but again, the vast majority, we believe, and from what we've heard from the millions that have reported back to the network, is that most will be able to manage at home. Now, when you're at home, what should you do? First of all, stay home as much as possible unless you need to seek medical care. We know that those that are at home, it's important you don't go out to public places, that you significantly take care of yourself, get additional rest, stay hydrated, take over-the-counter medicines like acetaminophen, oftentimes will help you feel better. We've heard reports of people taking Dayquil and NyQuil as a good way to the symptoms on a day in, day out basis as they are fighting the virus. Also, stay in touch with your doctor. Be sure to call before you just show up. Many offices, as you know, are still having very limited in-person visits, but you need to be careful and be aware of what the emergency warning signs may be. And if your symptoms are worsening, what you should do and when you should continue to seek information. And then finally, avoid public transportation, ride sharing or taxing. Of course, anywhere that you may be encountering large crowds of people as you're caring for yourself. Tips for staying hydrated. There are some different things that you can drink to stay better. Calf tea, water with lemon, especially a warm water with lemon, soup, ice chips, all of these things are very good to help you stay hydrated. Now, you should avoid the sugary sports drinks, coffee, fruit juice, ginger ale, or alcohol. All of these actually can increase that inability to stay hydrated, so it's important to avoid those things. Now, the CDC is very clear about continuing to separate yourself from other people, stay in a specific room away from your other family members or pets, use a separate bathroom, continue to wear a mask as much as possible, and communicate with your close contacts. Let them know that they may have been exposed to COVID-19. And actually spread COVID-19 starting 48 hours or 2 days before you ever have symptoms or test positive. So it's by informing your close contacts and letting them know that we can help to protect our loved ones and our friends. Again, there is a lot of additional guidance at the CDC website on those living in close quarters or shared housing. But the main thing is that if you are diagnosed with COVID-19, realize that it's important to share this information. And you may actually be contacted from someone with your local health department that is calling to help understand the spread and to, again, do that contact tracing. Now remember, while you're at home, monitor those symptoms and other symptoms. If they worsen, then follow those care instructions that have been provided by your provider. Know how to get in touch with your emergency personnel if possible, and also what the closest hospital is. Look for these emergency warning signs and definitely seek emergency medical care when needed. These include trouble breathing, persistent pain or pressure in the chest, confusion, inability to wake or stay awake, bluish lips or face is also a very important sign to look for. That means the person is not getting enough oxygen. But this is not an all-inclusive list. So please definitely, if you have concerns, if you think your symptoms are worsening, then call 911, local emergency facility, and certainly stay in touch with your own personal medical provider. Now, we always like to take the opportunity to reinforce how to reduce your risk of COVID. Remember, there are the 3 W's that the Surgeon General has continued to reinforce. Wash your hands frequently using soap and water for 20 seconds. Watch your distance, keeping 6 feet apart and avoiding large crowds, and wearing a mask to prevent the spread of COVID and protect others in your community. There's also a great handout, a download at CDC on 10 things you can do to manage your COVID symptoms at home. And so again, we'll reference that and send it along. It'll also be on our COVID-19 information. So we only have just a few moments left. And actually, I think we're going to go ahead and skip this poll just so we can get to more of your questions, because we do have a number of questions that have come in. So the first question is around the use of nebulizers in schools. And this is a common question that we have gotten so many times in our webinars. And I know that, Ron, you may not be as equipped to answer that today, given the topic, but what our experts, especially our national spokesperson, Dr. Parikh, would suggest is to avoid the use of nebulizers if at all possible. It's much safer to use an inhaler versus a nebulizer so that those particles are not aerosolized. And to use a nebulizer, make sure that you're using it in an isolated area with an open window if possible. I know that it's turned to winter and many of us are iced and snowed in, but certainly trying to get good ventilation and keeping others away from those aerosolized particles is very important. Now, the next question comes from a patient who's on the line who says, my specific concern is that I have a lot of multiple chronic conditions, and is it safe to get either the treatment or the vaccine if I'm living with multiple chronic health conditions? Perhaps, Ron, you feel free to answer to the degree that you feel comfortable, and then I'll address it as well.
Okay, thanks, Tonya. Certainly that would have to be in consultation with your physician or physicians. I can't speak to the vaccines because I'm not privy to the data from their clinical trials. In regards to the monoclonal antibodies, we have a set of criteria of patients that we included and excluded in our clinical trials. So I don't know what your particular conditions may be, and I can't therefore answer more fully, but I would definitely consult with your physician, and always, physicians will err on the side of caution, but we have to take every patient's individual situation into consideration, and also the risk versus benefit. So all of those would be considered in making that decision.
Absolutely. Yeah. And I think that it is an important conversation to have with your physician if you have underlying chronic health conditions. And again, you can have that proactively, but then also when exposed to COVID-19, if you have concerns about what your treatment path should be or in taking the vaccine. For most with chronic conditions, we are recommending the vaccine. And again, in the tens of thousands of patients that have been included in the clinical trials, many of them have been living with multiple underlying. So our next question actually comes, in addition to testing for the original virus, isn't testing for knockoff genomes important in any treatment policy? Do you feel comfortable answering that one?
Sure. I can tell you this, that at Regeneron, remember in my presentation, I mentioned that we can select the best antibodies for development. We select those antibodies even based on the potential for variants to occur in the future. And in fact, we predicted at Regeneron, what variants might become available. And we chose and designed our antibodies to be protective against them. So while it would be insightful, it would not necessarily be required.
Okay, great. Now this next question actually comes from an allergist on the line who says, in the antibody treatment studies, was there any look at patients that were actually using biologics for other chronic conditions?
No, I don't recall. I do believe that those patients that were on other biologic therapies, and because of the potential for the immunosuppression of biological drugs, those likely would have been excluded in the clinical trial. I don't recall that any patients were taking other biologics.
Okay, and then a question from Stuart who says, how do you explain the steep decline in viral load with placebo versus treatment?
Good question. Patients generate their own antibodies. And so if we identified that those patients that mount their own antibody response probably don't need to be treated because many of them will clear the virus on their own. And that's why we've all heard about patients that can still spread the disease without having any symptoms or even ever knowing that they had the disease. That's because their body has produced antibodies and they are eliminating that virus.
So that follow-up question, are the monoclonal antibodies used in patients that are already producing their own antibodies?
Yes, so we looked at patients that produced their own antibodies and those that did not, but we also studied that overall population. And we looked at whether or not the reduction in viral load and the reduction in medically attended visits was what we call statistically significant in each of the groups, the seroantibody negative, the seroantibody positive, and the overall population of the combination of seroantibody negative or seroantibody positive. And there was still significance in the overall population, be they seroantibody positive or antibody negative.
All right, we have time for just one more question. It comes from Stuart, who says, was there a significant difference in hospitalization or in complications from COVID between the placebo and treated patient arms?
Yes, there was a significant reduction in what I mentioned, the medically attended visits, and that did include hospitalizations. So yes, there was a statistically significant reduction in hospitalizations, but we lumped all of those medically attended visits together. We looked at others individually, but they were statistically, we aggregated all of those various means that by which patients would seek attention, and we did that analysis, and that was statistically significant.
Wonderful. Thank you so much, Ron. That was very informative, and we appreciate your time and expertise today. I'd like to thank you all for listening as we explored the new treatment approaches to COVID-19, and truly do appreciate Ron's joining us as well. Please plan to join us for our next COVID-19 webinar in our series, where we'll look at addressing COVID-19 vaccine hesitancy in high-risk communities. You can register on our webinar page under news on our website. Again, all for joining us today. I'm Tonya Winders, the CEO and President of Allergy and Asthma Network. And again, on behalf of our staff, we appreciate your time, and we hope that you'll work alongside us each and every day so that we can continue to breathe better together. Thank you and have a wonderful day.